We have image-based robotic systems, one those which are based on CT scan and one which are based on X-rays with dedicated markers. Mako from Stryker and QVIS from Merrill are based on CT scan, and the ROSA from Zimmer is based on the X-rays with dedicated markers. In CT scan-based robotic systems, we do preoperative CT scans. In total hip, we do the CT scans of both the hips and both the knees. And in the total knee replacement, we do the CT scan of the ipsilateral hip, knee, and ankle. We'll see first the use of Mako robot for THR. In this, we do a CT scan of both the hips and the knees of the patients. And the CT scan images are then used to generate a 3D model of the patient's hip. The 3D model is then used to create a customized surgical plan for the patient. Detailed planning is done to decide about the size and the placement of acetabular cup and the femoral stem. After the CT scan is done, we can make adjustments in the, after the CT scan, pre-planning can be done, and before the surgery, we can do pre-planning. You can see that one-sided hip has been already replaced, and the other side is that has been planned. And we can see how the implant will be positioned. We can rotate the model and see how the implant is placed. We can see how much the anterior column and posterior column have to be rimmed. What size of implant has to be used, that also can be planned. We can see how much medial wall is remaining after the rimming. We can enter the spine values, the pelvic tilt and the sacral slope, and then make adjustments. We can have virtual movement of the limb and see where the impingement is occurring, whether there is a bone-to-bone impingement or metal-to-bone impingement, and we can adjust the anteversion and inclination accordingly. In fact, we can also have we can plan the stem also, and we can have a virtual preoperative image of how the X-ray will look post-operatively after having this plan executed. We can come to know about how much length can be adjusted, and what will be the combined offset, what will be the combined anteversion. All these things can be planned pre-operatively. And during operation, the robot helps us in rimming the acetabulum exactly to whatever we have planned. So the robot doesn't let us rim more than what we have planned, up to 1 millimeter, and even 1 degree of inclination and version, up to that much degrees of precision we can achieve while doing acetabular rimming. The cup placement is also helped by the robot. The robot doesn't let us place the cup in the more than 1 degree of what we have planned and 1 millimeter of what we have planned. And we can come to know in real time how much is the inclination and anteversion and how much the cup is proud. It tells us that now it is 5 mm proud. After impaction, it is becoming 4 mm proud, and that way it tells us where it is being placed. So then coming to the CT scan based robotic total knee replacement. In these, we do CT scans of the ipsilateral hip, knee, and ankle. And again, here we can see what is the exact patient-specific anatomy, how whether there are any defects, whether there are any cysts, how much osteophytes are there, and where these osteophytes are placed. And we can know the exact size of the implant pre-operatively itself. So hip, knee, and ankle, when we do, we get the precise alignment. We can also plan if you can see here, we can see how much of the medial osteophytes are there, how much medial reduction osteotomy can be helpful. We can adjust the flexion of the femoral component, we can adjust the varus, and depending on that, we can execute the plan. Intraoperatively, we get a real-time assessment of the ligament tension and adjust the implant accordingly. It gives us the exact balancing. The robot helps us in, it is a saw-based robot, so in real time also it tells us how much bone resection has been done. on both the sides, femoral as well as the tibial surface preparation. The QVs from Merrill is again a CT scan based robot for total knee as well as partial knee. But Burr is a cutting tool in QVs. It again has a CT scan which is done pre-operatively, and we can make changes pre-operatively as well as intraoperatively. ROSA offers both image-based and imageless options, and it uses 2D X-rays with dedicated markers which are then transformed into the digital and 3D replication of the patient's anatomy is done. So advantages of an image-based robotic system, because of the 3D modeling and CT scan, we can know about the patient's bony anatomy precisely and plan the surgery more appropriately. We can manage the osteophyte removal, filling of the cysts and defects very precisely. We can see the coverage of the bony surfaces with the implants and adjust them in a better way. Implant placement and changes in the positioning can be achieved pre-operatively, and intraoperative adjustments can be done in real time. So it is like we visit a new place or a new hotel and we use GPS and TripAdvisor much before we go to that place. And similarly, we can certainly study the patient's knee in a better way. However, there are some disadvantages of image-based robotic systems, that radiation exposure is there and additional cost for CT scan. However, I think that advantages are far more than the disadvantages. Thank you. Thank you.